Hello, everybody. My name is Robert Riley, and I'm an interventional cardiologist at the Christ Hospital in Cincinnati, Ohio. And I've been asked to speak on current perspectives on plaque modification or vessel preparation prior to PCI. These are my disclosures. So when we talk about proper vessel preparation, it really depends on the type of plaque that we're trying to modify in lesions that we're attempting to fix percutaneously. And we know that plaque composition is quite heterogeneous. On the one end, we kind of have the fibrofatty plaque, the softer plaque, foam cells, and lipid pools. Then as it matures, we get more calcified lesions. And in fact, when we get these really moderate to severe calcified lesions, we can take a slice of that and look at the histology, and it's very similar to bone. Now, diagnosing the type of plaque that we're trying to treat, intravascular imaging is key here. We've seen this time and time again, most recently in the IVUS-XPL and the ULTIMATE trials as shown in this meta-analysis, clearly showing a reduction in both short and long-term major adverse events when we use intravascular imaging versus angiography alone. And this is a flow chart for when to use intravascular imaging during PCI. And you can see that in the middle of the screen, one of the big important steps is the assessment for proper vessel preparation. The reason this is becoming increasingly important is that we're seeing increasing amounts of significant coronary calcification. And this is because we're seeing some increasing risk factors, so elevating age, increasing prevalence in things like diabetes, renal failure, hypertension. We're also treating patients percutaneously that we simply weren't treating 10 years ago. We're seeing an increasing prevalence in the complex high-risk PCI, and then our valve patients that we're treating percutaneously. So again, these are all associated with increased calcification, so this is something that we're going to continue to have to improve on in the cath lab. This is important because not only do we see reductions in technical success rates in people with significant coronary calcification, we also see decreases in procedural success, and that's because of these significantly increased MACE rates in patients with significant coronary calcium, as seen in a meta-analysis of several trials here. And this is because we see several implications of that coronary calcium as we're doing our PCI procedure, both in the vessel preparation side, so having to use specialty or NC balloons or atherectomy devices and the risk for no reflow, vessel dissection, et cetera, to both the stenting event where we're having trouble both getting our stent there and adequately deploying it once we do get it there. And we know that this inhibition of proper vessel expansion, stent expansion, leads to increases in both short and long-term event rates such as stent thrombosis and restenosis. So when we talk about adequate preparation before we move to the stenting, it sort of is on this continuum with the plaque composition that we talked about earlier. So we have kind of the utilization of semi-compliant balloons and our sort of soft fibroatheromas, very typical PCI that we're all used to. But as we get more fibrotic and calcific, we start talking about specialty balloons, such as NC balloons, cutting balloons, et cetera. And then when we get to the real moderate to significant coronary calcification, we start talking about atherectomy and intravascular lithotripsy. And really the goal, regardless of which device we're using, is to really get full expansion of a 1-to-1 size balloon. Now, this is an algorithm that we released recently in the SKY guidelines for PCI for complex CAD for specifically treating patients with significant calcium. And you can see here that you're going to notice that via either angiography, so seeing that significant calcium on both sides before you even do any injections on Cine or IVUS, or excuse me, Cine on fluoro, and hopefully the use of intravascular imaging, again, hoping that that becomes more routine. We're looking for things like big arcs of calcium, long lengths, thicknesses that are going to push us more towards the mechanical or laser atherectomy or lithoplasty. Then we're going to go back to the sort of NC or squaring balloons again, really with that goal of a 1-to-1 balloon dilation, getting it adequately expanded before we get to our stenting and then image-guided stent optimization. So if we do need atherectomy, here's a slide showing the 3 that are on the market in the United States. We have rotational and orbital, as you can see on the left. Laser doesn't have as big of a market share at this point, but it is still available, and it's really important for cases where, for example, you've got a wire across, but you can't get a microcatheter across if you want to exchange for one of your atherectomy wires, or you're trying to free wire with an atherectomy wire. Laser is still really important here and can be very nice in order to get through those types of lesions. We know that when we do use atherectomy, our technical success rates go up significantly. You can see here with rotational atherectomy on the left, and then orbital atherectomy on the right. We know that we have significant improvements when we use atherectomy there for these moderate to severe calcified lesions. We also know that when we use atherectomy properly, we can really shift that delta that we saw in the significant increase in periprocedural MACE rates. We can really shift that to insignificant when atherectomy is used properly in these heavily calcified lesions. This was an interesting study looking at PCI in patients who did not have significant calcification versus those who did have significant calcification who had atherectomy used. And again, you really see no significant difference both in the short and long-term outcomes there. This is also true for the specialty balloons that are on the market. This was a study looking at AngioSculpt, relatively complex lesion subset, looked at 200 patients. This was several years ago. Again, showing very similar procedural and clinical success rates as with the atherectomy devices, and on an IVUS sub-study showing significant improvements in acute gain on imaging as compared to direct stenting or plain balloon angioplasty with routine balloons alone. There's also a role for these specialty balloons potentially after atherectomy. This was an interesting smaller study in CCI recently that looked at after atherectomy in heavily calcified lesions, the use of a specialty scoring balloon, in this case a Wolverine balloon, versus just an NC balloon. And interestingly, pre-procedurally, significant improvements in acute lumen gain, and then post-stenting, significantly increased minimal stent areas as opposed to just the NC balloon. So again, a really nice role for specialty balloons after atherectomy here. We've also seen the rise of intravascular lithotripsy. We saw the Disrupt CAD1 study showing very good technical success rates with very low periprocedural events. We're all very excited and anticipating the Disrupt CAD3 results, which we're hoping for later this year. And then with our European colleagues who are now using it routinely, very excited about this becoming part of our armamentarium for significant calcification. So here's a few cases just to show the use of devices in this patient population. Here you can see a heavily calcified proximal RCA lesion, and then we actually have one that's a little bit more hidden, but in that sort of mid to distal as we come around the bend there. We can see that as we just try to get a balloon in to get our IVUS catheter in, obviously if the balloon won't go and it's pushing the guide out like that, low profile balloon, you've probably got a significant lesion with heavy calcification, which is then confirmed here on the bottom right when we look at our IVUS. You can see we see our first lesion here, heavy calcium, pretty tight down there, much more so than we might have thought angiographically. We then got that mid segment, as you can see there, getting to our proximal lesion, which again, you can see pretty heavy calcification, very circumferential, some nodules there as well. In this case, we use rotational atherectomy followed by NC balloons, and we get a very good, technical result, as you can see here on the right. So our second case here, a relatively calcified LAD, as you can see there, both in the proximal and the mid segment. So in this case, IVUS showed us dense calcium for a very long length, so we decided to use rotational atherectomy again. In this case, I thought was really interesting because it showed sort of the NC balloon did not dilate very well, but the Wolverine after the fact dilated actually quite well. So this goes back to that small CCI study showing that we do have a role for these specialty balloons even when we've already done mechanical atherectomy. You can see here on the IVUS run, there's this circumferential fracturing of the calcium as opposed to the big dissection planes that we might see with our NC balloons, which are shown histologically. There on the right side, you see these small little dots where the blades actually dig into the calcium so that they're not creating big dissection flaps. We're seeing just small little punctate fractures in that calcium ridge, which we really need for proper vessel dilation so that we can get the stent to adequately expand. And then this is our final angio after atherectomy and stenting. This is our third case here. You can see there's clearly a mid-circumflex lesion, heavily calcified, pretty tight. The proximal lesion was interesting to me when it got referred to me. The referring said that they had performed FFR. The proximal lesion said it was non-significant. I was going to image the mid lesion anyway. You can see I did a small balloon there just to get the imaging catheter down. We were able to do OCT in this case, and you can see actually that proximal lesion wasn't as bad as I had thought, so that does fit with the FFR. Heavy calcified lesion there in the mid with some nodularity there. So we decided to perform IVL, intravascular lithotripsy, for this lesion, as you can see here on the left. Post IVL, we've got almost a stent-like result, and it was absolutely gorgeous, the results that we were seeing during the study. And then you can see here the post-PCI result, again, really, really nice result. So in conclusion, vessel preparation is really key for optimal stent deployment. The goal is really a one-to-one balloon dilation, and calcific coronary artery disease is really a growing problem, and that's really important when we think about vessel preparation. We have to use intravascular imaging in order to diagnose what the lesion characteristics are so we can know how to properly do vessel preparation. It's going to require preparation with NC and specialty balloons, atherectomy, intravascular lithotripsy, depending on the characteristics. And we do have algorithms available to help guide preparation in those patients with significant amounts of calcification. Thank you all very much. All right, so a few little, but I recovered. So I hope that if you want me to go back and do anything else, I certainly can.
I think that was fine.
Okay.
That was fine. I mean, I might edit out just the little blips, but I think overall it was great.
Anything you want me to redo?
No.
Awesome.
No, unless you want to. If you're not comfortable with any part of it, we can.
No, you're the pro. If you tell me it's good, then I'm good with it.
Looks good on my end. So
great.
Excellent. Thank you so much.
Absolutely. Thank you a ton for your help with that.
Oh, you're welcome. I'll let Dr. Isaac know yours is done.
Absolutely. Have a great rest of your day.
You too. Thanks.
Take care.
Bye-bye.